Diabetes is actually a group of diseases that are characterized by hyper or high glucose level, hyperglycemia, that results from defects in insulin secretion, insulin action, or both. And many people in the United States suffer from diabetes. And about a third of many of these cases, because these numbers change as we speak, are left undiagnosed, and the prevalence is increasing. And minorities as well as older individuals are the people who are most commonly affected. Now, there's different classifications of diabetes. There's type 1, then there's type 2, and then and we'll talk about these. Then there's latent autoimmune diabetes of adults, LADA. Then there's gestational diabetes, and then there's diabetes that are associated with other conditions or syndromes. So what does insulin do? Now, the pancreas is like a fish, or at least, it's described as looking like a fish. And the bigger, more rounded end is located near the duodenum, so that it has a duct that attaches to the duodenum, whereby digestive enzymes are secreted to aid in digestion. So that the pancreas has both exocrine as well as endocrine functions. So exocrine means that there's a duct, there's a tube whereby whatever is being secreted travels through. Endocrine means that it's directly, it's directly transmitted through the blood. So there is no ducts. Sometimes endocrine glands are called ductless glands. So the head of the pancreas is responsible for digestive enzyme production and transmission to the into the duodenum. Did somebody shoot themselves? Thank you. I think it's Faye. I'm sorry. Thank you. So that the tail of the pancreas is where the endocrine functions lie. So that's where the insulin production as well as glucagon happens. So that what insulin does is it basically helps with the transport. Insulin binds with glucose and carries it into the cell. And it helps with both, not only the transport, but also the metabolism of glucose for aerobic respiration. It also stimulates the storage of glucose in the liver and in muscle as glycogen. Okay, so that when you learn about GI hepatic next semester, they'll talk about the many functions of the liver. And one of the problems is that the liver, when it starts to not work right or malfunction, whatever, you'll start to see a lack of storage of glucose, so that if the body gets stressed, the person will immediately become hypoglycemic. Insulin also signals the liver to stop the release of glucose, stop the release of glycogen, breakdown, not release of, but the idea of glycogen breakdown and the release of glucose. It enhances the storage of dietary fat in adipose tissue and accelerates amino acids into cells. It also inhibits the breakdown of stored glucose, protein, and fat. So basically, it works to facilitate what is in the circulation to be utilized appropriately. And the second to last bullet that talks about transport of amino acids into the cell, we'll talk about diet a little bit later on, but that's the basic premise behind why protein drinks are so helpful, and why sometimes they talk about you drinking milk when the person's hypoglycemic, because of the fact that it will help to facilitate the appropriate utilization of glucose. So type 1 diabetes is when the insulin-producing beta cells, so in the tail of the pancreas, the specific cells that make insulin are beta cells, are destroyed by either a genetic or an immunologic or environmental factors. So in other words, you're just not making insulin. So type 1 diabetes is when you have a limited, very limited production, excuse me, in the production of insulin. And subsequently, you're going to have an unchecked glucose production by the liver, and you'll have fasting hyperglycemia. And this affects about 5% of adults with diabetes. So not the population, but 5% of the people with a diagnosis of diabetes. Now, type 2 diabetes is what we call insulin resistance and impaired insulin secretion, and that affects about 95% of adults with diabetes. It usually has an onset over the age of 30, and it's increasing with children related to obesity. So it's a slow progressive disease that happens over years. So when you're looking at pathogenesis of diabetes, you're looking at two sources. You're looking at impaired insulin secretion from the pancreas, subsequently an increased baseline hepatic glucose production, okay? And then you're looking at the other side is gastrointestinal absorption of glucose and decreased insulin-stimulated glucose uptake from the muscle, all right? And both of those scenarios cause an increase in terms of hyperglycemia. Now, LADA, or latent autoimmune diabetes of adults, is a subtype of diabetes that's seen as an autoimmune situation with the beta cells, and it's slower than in terms of presentation than type 1 and type 2. They're not insulin dependent in 6 months of the disease onset, and the clinical manifestations are similar to type 1 and type 2. It's an emerging subtype, and it's basically in terms of this classification is going under changes as time goes on. Then looking at risk factors related to two major types of diabetes, type 1 and type 2. Type 1 is early onset. It's familial. They have a genetic predisposition. There may be some immunologic or environmental, which would be viral or toxin factors. So that type 1 is generally seen in young population. And as I told you, with chronic illness, and we've discussed with chronic illness, one of the big problems is compliance. So that when you're looking at any chronic illness, compliance is a huge issue. So with type 1, if you're looking at a young population, adolescent, pre-adolescent, there's a whole issue with that component that's compounded because of body changes that's normally happening, and that you're looking at altered body image. So that type 1 diabetes has to, with the population that it generally affects, initially you have to work very closely. Not that you don't have to work closely with type 2, but there's an adherence issue that you need to focus on more closely. Type 2, you have to worry about obesity, age, previously identified fasting glucose or impaired glucose tolerance. Is the person hypertensive? Does the person have an HDL that's less than or equal to 35 mil, or the triglycerides are high, greater than 250? Do they have a past history? If, for women, if they have past history of gestational diabetes, or if as a baby you were over 9 pounds. The baby that was delivered was over 9 pounds. Sorry, not the baby itself, but the baby that was delivered is over 9 pounds. So gestational diabetes or the baby delivered is over 9 pounds. So that woman would be, subjected, would be a candidate for type 2 diabetes. So the clinical manifestations depend upon the level of hyperglycemia, and then the 3 Ps: polyuria, a lot of urination, and that has to do with the fact that you've got so much glucose in your urine, so it's pulling fluid off. Polydipsia, because if you're urinating more, now you're going to need more fluid. Polyphagia, you want to eat more. You're hungry. Also, in terms of clinical manifestations, you have to worry about fatigue, weakness, some vision changes, any tingling or numbness in hands or feet. Do you have dry skin? Do you have any skin lesions that are slow to heal? And any recurrent infections. With type 1, there may be some sudden weight loss. Okay. Now, the reason, we'll get into it, but the reason for the vision changes would be that you have to deal with microvasculature. And with microvasculature changes, the 2 places where microvasculature is most prominent that impacts you is in your retina, your eyes, and in your kidneys. So usually the vision changes and renal function are late presentations. So in terms of looking at diagnostic findings, primarily the biggest one to look at is actually the last bullet, and that's the hemoglobin A1C. And the hemoglobin A1C, you want to keep it below 7, all right? So you start worrying about it if it's like 6.5 rising to 7. In terms of all the other things are important, but when you're at your primary care provider, and the hemoglobin A1C works is a very good picture, and it's not a snapshot. It's really looking at the life of the hemoglobin, and in terms of looking at 90 to 100 days as to what's been happening in the body. And the hemoglobin A1C is you can have a snapshot of a glucose and it could be fine. But the hemoglobin A1C tells you over at least a 3-month period what's been going on. So it's much better diagnostic tool than just looking at a snapshot in terms of a single glucose level. But the other hallmarks that you may also need to consider would be a fasting glucose of 100, as it says there, 126 or more, a casual glucose exceeding 200 because maybe you just ate. And in terms of looking at the ADA diagnostic criteria, that talks about in general what once you've been diagnosed as diabetic, the parameters that follow accordingly. And you're looking at what's listed below. And that's a fasting glucose, like we just mentioned, of greater than 126, a 2-hour plasma glucose level of 200 milligrams per deciliter, or a random glucose higher than 200, and the hemoglobin A1C. So those 4 bullets are what the ADA recommends. And these numbers actually changed. There was a time when your fasting, not your fasting glucose, but your spot glucose checks, they wanted it to be a tighter control, lower. but they actually found that that was causing problems in terms of sequelae to hypoglycemia. So subsequently, they raised it back up again. So this is what is considered normal. In medical management of diabetes, the main goal is to normalize insulin activity and blood glucose level to reduce the development of complications. And as I just mentioned to you, the hemoglobin A1C of less than 7. And diabetes management has primarily 5 components: nutritional, exercise, monitoring, pharmacologic, and education. Now, in terms of your dietary management goals, you want to control diet caloric intake or attain or maintain a reasonable body weight. And you want to have good control of your glucose levels. You want to normalize lipids and blood pressure to prevent heart disease. Because remember that how energy is utilized. The first is obviously glucose. The second is fat, and the body works to hold on to protein. So if you get to the point where protein is being utilized as an energy resource, then the person's malnourished. Okay. All right. So the role of the nurse is to be knowledgeable about dietary management. Now, in terms of through the years, all right, there's certain members of the healthcare team that did not exist 50 years ago. For example, respiratory therapy. That was totally the responsibility of the registered nurse back in the 50s and 60s. So you're looking at, as things became more and more complex, there became more and more of a specialization accordingly. Dietary is another. So that nursing, as far as nutrition goes, is responsible for screening. In terms of doing the actual assessment, that's where the registered dietitian comes into play. That doesn't negate the fact that nursing, the registered nurse, doesn't need to know about nutrition. You need to be aware of diet. And usually what you see is that's outlined as saying 1,800 calorie ADA diet. So, that's the American Diabetic Association, a dietetic association. Actually, both are in agreement with this. And that's based upon somebody, every time you see something that's generically put out there, it's based upon somebody weighing 150 pounds. So you have to appropriate BMI for that individual, body mass and more about that when you talk about GI hepatic. You want to make sure that as the nurse you communicate important information. You want to communicate important information to the dietitian or other individuals that are part of the team. You want to reinforce patient understanding, patient education, and you want to support dietary and lifestyle changes. I always think about this when I discuss these type of topics in terms of lifestyle and patient understanding. I always remember this older was with a clinical group from the hospital on the evening shift. And when we did her finger stick at 10 o'clock, it was always in the 300s. And well, not always, it was the 2 days, all right? So the first day, then we covered her. The second day, we covered her with insulin again. And I dropped something on the floor. And when I went to pick it up, I saw underneath her bed, she had a rice cooker. Now, 2 things you got to know about this. One is that any piece of electrical equipment, before it gets used in the hospital, has to be cleared by biomedical engineering, that it's not going to cause a fire, blow up, whatever, okay? So that's number one. But number two, it wasn't that she wasn't eating, because the tray was hardly touched. It was basically that she didn't like the food. Now, Europeans, as far as starch goes, it's potatoes. But people of Asian, Caribbean background, starch is usually rice. So that you have to be sensitive to what people normally eat. And then you have to how much is acceptable. So it's not that you can't have rice, but that you can only have a certain amount of rice. And I'll never forget the look on her face, as long as I can remember, when I found the rice cooker. She just like laughed, it's like she was busted. But it's like, to make sure that you don't bypass. This was many years ago now, but you don't bypass, just because somebody may not, there's people that you can have interpret so that they understand, so that it's in their best health, their best interest, that you're educating them, and you make sure they understand. And if they don't understand, and that they have assistance in terms of being able to follow. So the idea is that you have to be cognizant of what people's normal patterns in life are, and you have to see how you can adjust them in a way that would be most congruent with what they're expected, what their normal lifestyle is, so that they can be better and more compliant. So, and that's basically what I just meal plan. And you want to consider the food preference, right? And cultural and ethnic backgrounds. So also eating times. You can't like eat, even though we generally eat very heavy at night, it's best not to have a heavy meal at night. It's best to facilitate an equal distribution of calorie intake accordingly. And then the idea of looking at what the diet history is of the individual. You want to look for, is there a need for weight loss, which usually there is. And if with type 1, if there is a need for weight gain, and how you're going to maintain the weight. So the dietitian is going to make that assessment. They're going to look to what your normal BMI should be. Then I think you should all be familiar with the BMI charts, because we've been talking a lot about that lately, right? One of the things that with fast foods, I remember when I was younger, when I was a kid, just say it, like in high school, McDonald's wasn't McDonald's it is now. Like, you got a hamburger, but it was a hamburger. They didn't have Big Macs. And actually, in terms of, my cat just walked across sorry. Hopefully she didn't do anything here. No, okay. So, so basically, a Big Mac in terms of calorie intake is 2,200 calories. Now, the Big Mac alone. So you think, well, you got meat, you got salad in there, but it's actually 2,200 calories. Now, remember, in order to maintain body weight of somebody who weighs 150 pounds with moderate physical activity, that's 1,800 calories. So if somebody has a Big Mac alone, that's taking you way over the limit. So the idea of understanding the importance of looking at calories, looking at calorie counting, And the other thing that's also harder for older people, myself, is that, as you get older, your metabolic rate drops off. So that what becomes normal caloric intake subsequently somewhat diminishes because of the decrease in terms of your metabolic function. So there you go. So in terms of taking all of that into consideration, the dietitian then decides how many calories is required. And in terms of looking at, carbohydrates, fats, as well as other sources of protein other than animal, and the importance of increasing fiber accordingly. So that the person has a dietary plan in place, and that subsequently the individual then works with that. And sometimes, and if you have the right dietary plan, you can avoid having to take medications. And if you look at what your glucose intake is and what you can tolerate, subsequently you can stave off having to take oral hypoglycemics as well as definitely insulin. Not always, but frequently. So in terms of looking at glycemic index, so the idea of looking at combining starchy foods with protein and fat slows down the absorption and your glycemic response. Raw or whole foods tend to have lower responses than cooked or chopped or pureed foods. And it's always better to eat whole fruits than juices, because remember, juices are a bunch of fruits that have been, utilized to make juice. So, it's this also decreases, it also helps the eating the whole fruits, the glycemic response because of the fiber, and slows the absorption. Adding foods with sugars may produce lower response if eaten with foods that are more slowly absorbed. So what this is all telling you is that you're looking at the absorption rate accordingly. So you want to slow down the absorption of glucose. Other dietary concerns, alcohol. Alcohol is extremely high in glucose. Nutritive and non-nutritive sweeteners, you have to be careful in terms of those utilizations, and then misleading food labels. So the FDA is supposed to rely on them accordingly, and they're the administration, right? So they're supposed to what's on those labels is really what's in those foods. And as I mentioned to you, you really need to know when you're out there eating fast foods exactly, or in a restaurant period, what caloric intake is. Because, when you go out to eat, it doesn't stop, not just if you're diabetic, but in general. Now, know that exercise lowers blood sugar. It aids in weight loss. It helps with easing stress and maintaining a feeling of well-being. It lowers your cardiovascular risk, because obviously weight is going to play a role in terms of your cardiovascular risk. In terms of exercise precautions, exercise elevates blood sugar levels, and subsequently insulin needs to be adjusted. Insulin normally decreases with exercise. So your insulin production normally decreases with exercise, and patients with exogenous insulin, meaning you're supplementing insulin, should eat a 15 grams of carbohydrate snack before moderate exercise to prevent hypoglycemia. And there's always a potential for post-exercise hypoglycemia accordingly. And you need to monitor the glucose levels, and there are certain gerontologic considerations that need to be made.
Professor?
Yeah.
On the bullet, when it says exercise elevates blood sugar levels, if the glucose is being utilized for exercise, how does it elevate the blood sugar level?
Because of the increased metabolic, because of the exercise. So once you're exercising, you're increasing the metabolic rate. Subsequently, there's more of a release of glucose from actually the muscle itself. In terms of, the muscle needs itself, and as a result of also the liver in terms of glycogen storages. Once you increase the metabolic rate, glycogen storages are then made to be glucose sent out, and subsequently to meet the metabolic needs as they present themselves.
Okay, thank you.
Would at the same time the release of storage of glucose from the liver during exercise cause this also?
Yeah, because once you start to see an increase in metabolic needs, insulin is there to facilitate the liver to take glycogen and make it and release it as glucose. So that's why when you're ill, all right, if you're critically ill, all right, your metabolic needs go up. And one of the things that people who are not diabetic, if they're in an ICU and they're placed on an insulin drip, you find that their glucose levels have a tendency to be high, because the liver is being pushed to release more glucose, because your metabolic needs have doubled. You're septic, your metabolic doubled. So subsequently, the tail of the pancreas doesn't always necessarily keep up with the insulin production necessary. So there you go. So therefore, that's the same deal. You increase your actual physical activity, once again, you're increasing your metabolic needs. And that's why, like, when you're looking at exercise, you got to be careful with exercise, because there's two types of exercise. There's, I think I mentioned this already, aerobic, which is like walking and, your normal activities, but you're keeping normal activity going, and aerobic respiration for energy production happen. Anaerobic exercise is like bench pressing, weightlifting. And the problem with that is that, just as its name entails, it's anaerobic respiration, which is 2 to with that. And that's why hydration, when you're doing those anaerobic exercises, is really important, and monitoring that accordingly, because the lactic acid buildup in the long run could be very problematic. So that you have to be very careful with your exercise regime when you're looking at anybody with chronic illness, especially diabetes. All right, now insulin therapy. All right, glucose monitoring. There's, that's how you're going to manage yourself. So you're looking at self-monitoring of blood glucose. You have different categories of insulin. You have rapid acting, short acting, intermediate acting, and very long acting. All of those are to be considered. Your insulin regimen itself varies from 1 to 4 injections per day. Now there's different, and I think the slides I know the slides will show you later. But insulin, in terms of how it's administered, you can do it subcutaneously, all right? But they now have insulin pumps that, you just, in terms of anytime you stick somebody or you break the skin, there's always a chance of infection. And nowadays also they have these glucose monitoring devices that you don't have to do multiple finger sticks anymore. Some of you may have done finger sticks when you were able to do clinical or saw people doing them. And actually, you have to be careful with that because, somebody could get, an infection accordingly just from the cure, whatever that expression is, so you have to be careful in terms of that. So the less you stick somebody, the better off the individual is. Okay. And that's what you're going to see in terms of variation. So the less invasive, meaning the less times that you have to puncture or break the skin or go past the normal protection of the body, the better, the better off the individual is. And so that, in terms of insulin therapy, usually it's a combination of short acting and long acting. And there's different types of therapy that go along. And the next slide is the actual table that talks about looking at the different types of insulin. And Novolog is your fast acting insulin, and it's very fast acting. So if you're going to cover somebody because they have a high glucose, you have to make sure that you plan it around their food intake because it could really plummet the glucose level. Now, so in terms of looking at the first column, which is Novolog, the name the most is Aspart. It's very rapid acting. It's clear in presentation, and its onset is rapid. It peaks in 3 hours. Its duration is 3 to 5 hours. If you're mixing NPH with Aspart, you drop the Aspart first because Aspart is clear, and NPH is somewhat cloudy in appearance. And you always want to put it about, it says 5 to 10 minutes here, but no more than 15 minutes before somebody. If you don't see the tray of food in front of the patient, then you're going to hold it. And in the ICU, the insulin drips are Aspart, and they're, and you administer the insulin according to what the glucose levels are. Now, regular insulin is not rapid acting, it's short acting, and it is also clear. And it's a little bit longer, it's 30 to 60 minutes. And then it peaks in about 1 to 5 hours. Its duration is longer, 6 to 10 hours. And once again, you're going to draw up regular insulin first and then NPH. And then you have a little bit of a longer time interval with meal timing. So it's, instead of 15 minutes, this is 30 minutes. Now, Novolin or Humulin is NPH. And NPH is an intermediate acting. It's cloudy in appearance, just as Humulin 70/30 is. And its onset is longer, so it's 1 to 2 hours. It peaks in 6 to 12. Its duration is 16 to 24. And as I mentioned earlier, you're going to draw up the aspart first, and then the aspart and regular. That you won't have both, generally speaking. I haven't seen both clinically, haven't read about both clinically together. But if you're going to mix with NPH, either aspart or regular insulin, you're going to draw them up first because they're clear, and then the Novolog. And the reason you're drawing them up first is that you want to make sure that there's nothing floating in the aspart or the regular insulin. And then you're going to give this 15 minutes before the meals or 30 minutes before. If it's mixed with aspart, it's 15. If it's mixed with the other one, regular, then it's 30 minutes before meals. All right. Humulin 70/30 is a combination insulin. It's 70% NPH and 30% regular. And it's also intermediate because of NPH. It's also cloudy because it has NPH in it. Its onset is 30 to 60 minutes. Its peak is 2 to 12 hours, and its duration is 24 hours. And there's nothing it's going to be mixed with because it's already a mixed combination. And you give it 30 minutes before meals. And then the last one, Lantus, is your long-acting. It's clear. Its onset is in a little bit over an hour. There's no peak because it's constant. It's 24 hours. It can't be mixed. It's administered once a day at the same time, regardless for meals, because of its long-acting effect. So this chart is important to understand and to have a sense of. Okay. Remember that if you have somebody on an insulin drip, you're giving and the order will be written accordingly. You're giving either the aspart or the regular insulin. And pharmacy should be mixing that drip for you. That's an idea. Complications of insulin therapy. You're looking at local allergic reactions. You're looking at systemic allergic reactions. Insulin lipodystrophy, resistance to injected insulin, and morning hyperglycemia. So in terms of local allergic reactions, years ago, insulin used to actually come from animals. So like you'd have pork and beef. So you'd have to, and that's where also cultural concerns came into play. So nowadays, insulin is mostly synthetic now, so that you're not worrying about, the source of the insulin, but that may need to be a consideration. And then, also not only cultural, but, allergic components as well. There could be some resistance to the injected insulin in terms of tolerance levels. And with regards to morning hyperglycemia, it all depends upon, once again, when you ingested your food. That also plays a role. And insulin lipodystrophy, you're looking at, once again, in terms of not only injection sites, but primarily injection sites. Now, methods of insulin delivery, you have your subcutaneous, you have insulin pens, which are really important for people that may have visual issues, so that you have those pens, set to a certain dosage. You have insulin injectors or jet injectors and insulin pumps. And these things are all external to the body. But in the future, not actually in the future. excuse me, not exactly in the future, but because there were, some people on trial basis, you're seeing implantable insulin pumps as well. Now, with regards to educating patients in insulin self-management, obviously you need to make sure they understand the use and action of insulin. They need to know the symptoms of hypoglycemia and hyperglycemia and what they need to do. They need to understand how to do blood glucose monitoring. They need to be able to give themselves the insulin injection and to understand the pump, the piece of equipment that they might have in terms of the administration of insulin. So, what category of insulin, excuse me, is your rapid acting insulin, and that's Humalog, which is Aspart, and it really does act quickly. So insulin is what you're going to look at in terms of a rapid action or more of an acute presentation in terms of diabetes. So your oral anti-diabetic agents are primarily for type 2, all right? And there's a combination of oral drugs that could be used. And the major effect of these drugs is hypoglycemia. So that you need to make sure that you, as well as teaching the patient, to monitor their blood glucose. And obviously, as mentioned, patient education is vitally important. So that the sites of the action of oral excuse me, diabetic agents are, in terms of looking at type 2, you're looking at the idea of glucagon secretion and insulin secretion. So you want to decrease glucagon, which is the release of, glucose, just as its name suggests, and an increase in terms of insulin secretion. You also want to have, and notice the picture of the pancreas. It's, the tail that you're looking at, and you're looking at where the endocrine hormones are being released. And then in terms of insulin, the insulin and glucagon are made in that tail. So there you go. And then also with regards to looking at peripheral glucose uptake, as you see in muscles, and then in terms of looking at hepatic glucose output accordingly. So you can see the different types of glucose, of anti-diabetic agents. So when you're looking at the liver, you're looking at the primarily the biguanidides, and then you're also looking at the I can never say this right, thiazolid nodonis category. And then when you're looking at the muscle, you're also you're looking at the same in terms of what their actions are accordingly. Whereas with the amylin analogs, you're looking at more of a direct effect on the pancreas. And then also in terms of glucose absorption from the GI tract, in terms of those analogs. Excuse me. Anything else? So I realized I didn't put in here the actual list of oral hypoglycemics or the anti-diabetic agents that are oral. So I'll put that slide in as well. So I'll update these slides accordingly. In terms of, sorry. In terms of acute complications of diabetes, hypoglycemia, because you've given too much, you've overdone the therapy, diabetic ketoacidosis, hyperglycemic hyperosmolar syndrome, and to understand that there's actually a difference between diabetes and the hyperglycemic hyperosmolar syndrome. DKA is basically in relationship to the fact that your body is not making enough insulin. It can also be, causative agent. Let me back up. Your diabetic ketoacidosis is basically related to poor insulin production. All right. And your HHS is in relationship to primarily the person's dehydrated. Okay. So DKA is related to insulin, lack of insulin production. The HHS is related to somebody being dehydrated. So with looking at DKA, what the problem is that when you can't utilize glucose as an energy resource, what the body then utilizes is fat as its energy resource. Now, the byproduct of glucose metabolism is what? It's CO2 and water, okay? What's the byproduct of fat metabolism is ketones. So in actuality, if you're losing weight, all right, you're going to have ketones in your blood and in your urine. But how you're going to get rid of those ketones is by hydrating yourself. You're going to flush out your kidneys. So anybody losing weight needs to drink 6 to 8 glasses of water a day in order to flush out their kidneys. Okay. I mean, from my own, clinical experience, when morbid obesity or the specialty of bariatrics didn't exist, you still had people that were severely overweight. And I remember this one woman came to us and she weighed over 700 pounds. Now, we didn't have bariatric beds. Remember, you're considered in a bariatric realm if you weigh over 400 pounds. If you weigh over 400 pounds, then you're in a bariatric situation, okay? And you need bariatric equipment, bariatric bed, etc. All right. So just remember that somebody over 400 pounds, they need to have special accoutrements in terms of how we deliver care to them. So this woman came to us over 700 pounds. Well, we got her weight down to 200 pounds over about an 8-month period. But in the process, she lost her kidneys because we couldn't keep up with getting rid of the ketones. And so she ended up on dialysis accordingly. So what you're looking at with diabetic ketoacidosis is the fact that you can't use glucose because insulin isn't there to facilitate the appropriate use of glucose. So you're going to fats, and the amount of fats that's utilized is not healthy. The breakdown of, so that you have a buildup of ketones so that the patient is acidotic. Now, in terms of looking at treatment of somebody with DKA, they come into the emergency room, diabetic ketoacidosis, okay? So patient's going to present with a fruity smell to their breath. Well, they call it fruity, but I guess, I don't know. Yeah, it's fruity. It doesn't have a noxious smell to it. It's kind of fruity. They're going to have what we call, the Kussmaul respirations, deep to blow off. And then in terms of the smell comes with that. Subsequently, what you're going to see, if you look at the little box, you're going to see that their glucose level is above 250. They're going to have serum or urine presence of ketones, and they're going to be acidotic. And there's always a flow sheet, and I thought I put it in these slides, but I didn't, so I'm going to have to update these slides to show you an example of a DKA flow sheet, in the sense that what's monitored is the glucose level, what's monitored is the presence of ketones, what's monitored is the anion gap, which reflects the acidosis, and subsequently electrolyte monitoring, especially your potassium level, becomes really important, because as you correct the acidosis, your potassium level drops. So initially, you're going to not administer supplementation because the potassium level will be high. But as the person corrects, or as you correct the person in terms of their situation, you're going to see the potassium level drop. So the things that are monitored very closely in a flow sheet with regards to DKA is going to be their glucose level, their presence of ketones, their acidotic state, their anion gap, and then you're looking at electrolytes in terms of, as it corrects, you're going to see the glucose, the potassium level start to drop, that you have to start supplementing it. So once you bring down the glucose level less than 180 to 200, usually they cut the insulin drip. And subsequently, you then go to supplementation. Then HHS, or the idea of you're dehydrated. So when you're dehydrated, you see a concentration of electrolytes. So you see a concentration of glucose, and then you know that it's not DKA. So, okay. Yayo, go ahead.
Professor, with the same train of thought, would the people come in with DKA, would they receive like a large amount of fluid just to prevent damage to the kidney?
What usually happens is that they are hydrated, all right? But the deal is that you're looking at, they'll come in, you'll give them normal saline, and you'll put them on an insulin drip. And there's a whole evolved insulin protocol that is quite complex and needs in terms of following. But ultimately, what you're doing is that you're monitoring the hydration to a certain point, but it's not as severe as with HHS. So yes, you're hydrating. And then once as the glucose level monitor like the potassium accordingly. When somebody's in DKA, you're changing their IV fluids almost every hour on the hour. And there's a very close watch to what I just mentioned to you. So that's why the flow sheet is so important. So you're looking at the glucose level, you're looking at electrolytes, you're looking at acidosis, you're looking, presence of ketones. So as the process corrects itself, there's no need to go to fats anymore because you're utilizing glucose.
Thank you.
But there is. Yeah, no, so that yes, there is some level of hydration, but not to the extent that you see with HHS. Who that patient is, okay, I'll tell you who that patient is that I've seen is somebody before before this whole corona thing is like you have an elderly person who's found unresponsive in their apartment and they've been there for a day or two or three, so that they haven't been hydrated accordingly. So they're severely dehydrated. Their glucose level is up, but they don't have ketones because they still were able to make insulin but the insulin, but the dehydration just, challenged them further. And because they've increased metabolic rate, because of the critical state that they're in, subsequently, the glucose was more released, but there's no ketones there. And then you're looking at your pH. Your blood pH is normal in HHS, and but your serum osmolarity or osmolality is elevated. So what the serum osmolality is it's telling you particles in solution. So if you have more particles in solution, your serum osmolality is going to go up. So if you're dehydrated, your serum, it's going to be reflective in that serum osmolality. So the numbers here, all right, DKA, you got a high glucose, you're not making insulin, so your body went to fat, so ketones are released. Ketones are released, you get acidotic, and then you got to worry about your electrolytes, your anion gap, which also reflects acidosis. And in particular, you're looking at your, excuse me, you're looking at your potassium level as that acidosis corrects itself. Then with hyperosmolar the state, HHS, you're looking at somebody who's severely dehydrated. So they have a really high glucose level, but they're still making insulin, they're still using glucose, they're dehydrated, plus they're hypermetabolic because of the critical state they're in. Subsequently, you're looking at no ketones because you're still using glucose. You're not acidotic because there's no ketones. And now, because you're dehydrated, your serum osmolality is going to be elevated because there's more particles than what's normal. So that's the big difference. Now, in terms of treatment, both of these patients are going to get insulin. But the management is that once you get that person with HHS, once you get them adequately hydrated and their glucose level down, then, you cut the insulin. And it's not, theoretically, it's not as complex as DKA. Now, with hypoglycemia, that's when you've got your glucose level really drops, and you've got either too much insulin or your oral hypoglycemics, you got too much of them, you had too much exercise, and you didn't eat enough. So, your adrenergic response, and we talked about adrenergic, right? Sympathetic part of your autonomic nervous system. You're going to see sweating, you're going to see tremors because you're not having enough glucose, and tachycardia, nervousness, hunger, CNS. You're going to have an inability to concentrate, headache, all related to, remember, your brain needs two things. It needs oxygen and glucose. If it doesn't have either one of them or both, it's going to not function right. It's going to not function at all if it's totally depleted. And then with hypoglycemia, as you see listed, you're looking at severe components with regards to your nervous system in particular. So there's two terms that you're going to see in the clinical setting nowadays used. You're going to see what's urgent and what's emergent. All right, urgent means you got some time to fix it. So with urgent, that's if somebody has the ability to swallow, you're going to give them some concentrated glucose, some juice, or soda that's got glucose in it. And then you're going to retest in 15 minutes, and you're going to provide a snack with protein and carbohydrate unless the person plans to eat, because of the idea of glucose absorption. And that's why the milk component. Emergent, the person can't swallow. You could give them glucagon or an Ampy 50. And that's the 50 cc. I'm talking adults here. somebody who's considered an adult. So you're giving 25 to 50 milliliters of 50% dextrose accordingly. And there you go. So that emergent means you got to do it now, and the response needs to be now. Urgent is not. Okay, diet ketoacidosis. And then what you're looking at is the clinical features with regards to hyperglycemia, dehydration, and acidosis, as we talked about. But when you're looking at the prevention of DKA, there's something known as sick rules. And S stands for checking your glucose if you're not feeling well, like you have a cold or the flu or whatever. And then insulin, always take your insulin at the dose that's being required. And then with carbs, you want to, drink lots of fluid. You want to make sure that you're monitoring your glucose intake with the fluid. And then with ketones, you could check your urine or blood every 4 hours accordingly. And as we talked about, your glucose levels with DKA are elevated. You have to worry about acidosis. You have to worry about ketones because of the fat utilization. And then you're going to also look at your electrolytes. I did put it in here, sorry. An example of your diabetic, your DKA flow sheet in regards to looking at those things. So you're looking at electrolytes, blood gases, insulin, and then you're looking at the hydration accordingly. So that, DKA, you're going to hydrate the patient. With HHS, it's going to be much more aggressive because of the fact that the person's primary problem is dehydration. You're going to see the administration of regular insulin. You're going to reverse acidosis, restore electrolytes, and then you're going to have rehydration, and then look to, like I said, electrolytes. In the beginning, you're not going to replace potassium because the person's acidotic, but in later years, listen to me, in later hours, you're going to replace potassium because of the reversal of the acidosis. And this is an example of an algorithm that's used to treat DKA. I'm not going to hold you to memorize this. I just want you to know the specific categories, but understand that this is a complex problem. Okay, so HHS, you're looking at, the fact of the matter is it's a hyperosmolar state because the person is hyperglycemic, and that you are looking at a loss of water, basically, because you're dehydrated. So it's a very severe state, and if it's not corrected rapidly, there's a very high mortality rate. So that basically your treatment is going to be primarily rehydration and insulin administration. And then you're looking at balancing all of this out in terms of fluid and electrolytes accordingly. But it doesn't have the attached acidosis that a DKA does. And the primary issue behind this is to hydrate the patient. Now, long-term complications of diabetes, just to reiterate that both in DKA and both in HHS, you need to make sure that you're rehydrating the patient, because dehydration is an issue. It's a stronger issue in terms of HHS. In terms of long-term complications of diabetes, your microvasculature, you're looking at, as I mentioned to you earlier, your macrovasculature, rather, you're looking at accelerated atherosclerotic disease, coronary disease, subsequently cerebral vascular disease, and peripheral vascular disease, because of the plaquing related to the ketone, related to the utilization of fats. All right. The microvascular issue is your eyes and your kidneys, and the most common concurrent diagnosis to people that are in chronic renal failure is diabetes. So the people on dialysis are very often hooked to that. There's also neuropathic disease in terms of peripheral neuropathy, as you can see listed there, autonomic neuropathies, hypoglycemic unawareness, and because now your body is kind of equilibrated and it's used to certain syndromes, certain presentations. And then general neuropathy and sexual dysfunction. And then finally, in terms of looking at neuropathic ulcers, usually they're seen on the bottom of the feet, as you see as an example accordingly. Okay, so I'm going to give you guys a 5-10 minute break. What time is it now?